We have about 55 people, so I expect we'll have a few more. So let's get underway, folks. So let me, first of all, welcome everybody to the Path to a Safe and Effective Vaccine Remedy. Good morning and welcome again. We're delighted to have you here with us. Just about a year ago, we essentially had a very similar webinar looking at the initial stages of the pandemic, and we're delighted to have an opportunity to have some exchange together today with respect to the emerging improvements that are going on in the pandemic and the level of inoculations. So we're going to have a wide-ranging discussion, and delighted to be here. My name is Terry Sullivan. I'm a part-time faculty member and a longtime associate of the Lievonen School and the Institute for Health Policy Management and Evaluation. I'd like to read the acknowledgement of the territory. The Lievonen School of Public Health wishes to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississauga of the Credit. Today, this meeting place is still the home to many Indigenous people across Turtle Island, and we are grateful to have the opportunity to work on this land. So without further ado, I'm going to introduce our talented panel, starting with Mark Lievonen. Mark is quite a remarkable person. He's had a large fraction of his life at Sanofi Pasteur working on vaccines, and he's been honored in multiple ways, which I won't begin to acknowledge. But among other things, he was co-chair of the COVID-19 task force. Secondly, let me introduce Vivek Goel. Dr. Goel is a public health physician. He ran a public health agency when it was first stood up, very strong academic scholar and administrator at the university. And he is the incoming president and chancellor at the University of Waterloo. Jeff Kwong, who's joined us today as well, is a public health scientist, family physician, a very talented researcher focusing on infectious disease vaccines. And we're delighted to have him here. And he has an association with the Institute of Pandemics, which was created last year. Finally, and not least, Jennifer Gibson, who is director of the Center for Bioethics at the University of Toronto and the Institute, also connected with the Institute for Pandemics, and is the Sun Life Chair in Bioethics. So with that, let's get started, and perhaps we'll begin with Mark.
Great, thanks, Terry. Thanks very much. Great to be with everybody, a real pleasure. As Terry mentioned, it was over a year ago, just about a year ago exactly, that we did a similar panel. We talked about the path to an effective vaccine and what that might look like. At the time, we didn't know it, but that was really the engagement or re-engagement of myself in the vaccine world. And so a lot has happened in a year, and I'm really looking forward to sharing some of that and talking about some of the things. So let me start with what was the situation a year ago. And I'm going to briefly summarize what I talked about. It was a 20-minute talk. I'm going to try to do it in about 3 minutes right now. But I talked about the history of Connaught Labs with the university and how it evolved into Sanofi Pasteur. Little did I know at the time that that would become front page news and on the national news many nights in a row. And it's an ongoing story. I talked about the potential vaccine candidates. And at that time, there were 100 plus. And I remember I ordered what they were, and I was very specific. And I talked about protein-based vaccines, viral vector vaccines, DNA vaccines, and this thing called messenger RNA vaccines, which while the science was there and research had been done, we kind of thought maybe that's something out there. We'll see what would happen. There'd never been an RNA vaccine or therapeutic ever commercialized before. So we talked about that, and we know how that story has turned out. I also talked about vaccine development stages and timelines. And I mentioned traditionally or typically it's 10 to 15 years 4 to 5 years was the fastest ever for Ebola and measles. We were talking about 12 to 18 months here. Maybe it's a possibility. And I also said, in some cases, we don't have vaccines. And we can think about HIV, AIDS, and malaria and other diseases. And then I also talked about, and once we get a vaccine, we will have other issues to deal with, such as manufacturing, supply, distribution, allocation, and immunization. And finally, I talked about other potential issues. I talked about vaccine hesitancy, which turns out to be a real issue. I also talked about living without a vaccine, which fortunately we did not have to do because frankly, we weren't very good at living. We wouldn't be very good at living without a vaccine, it seems. So that was the situation a year ago. So what's the response? Well, the government formed, among other things, and I'll talk about the response from the role that I had, they formed the Immunity, Therapeutics, and Vaccine Task Forces. I became shortly within a week of this seminar last year, co-chair of the Vaccine Task Force, along with Joanne Langley. It's a group comprised of academic, scientific, and industry experts that was put together. Our mandate was to provide advice to the government of Canada on securing safe and effective vaccines, COVID-19 vaccines for Canadians as soon as possible. And we were looking at, our mandate included looking at domestic candidates, international candidates, and potential biomanufacturing investments. We ended up, as I hope you'll all know, or many of you will know, we ended up recommending 7 vaccine candidates across 4 different platforms. And I'm pleased to report that 4 of those have been approved and 3 of those 4 are being utilized. And, you know, part of the challenge was at the time, we were recommending vaccines to be procured when they had not yet been approved by Health Canada. This was quite a challenge. And I remember our first ones were publicly announced on August 5th. So it was quite something, a lot of activity there. And I'm very pleased to say that the government took our advice to heart and were very responsive. Just 2 key principles that I want to mention. We had 2 principles were battlefield readiness and science rules the day. And they may seem somewhat cliche-ish. Just let me talk for a second about battlefield readiness. That really was the fact that we would proceed based on incomplete information and we would make decisions based on the information that we had. One example that strikes me, when we were first looking at what would be the high-risk group, what would be the group that should be prioritized for a vaccine, we pulled together 4 or 5 members one Sunday in August of last year, and after about a 2-hour session, came up with 10 million people who should get the vaccine first, those in long-term care homes and healthcare workers, those whose health was at risk. And that 10 million ended up being the basis of the first negotiation for vaccine deliveries. Once our work was done, NACI and other groups looked at it and they spent more time deliberating on this kind of thing and came up with a very similar number. But that's an example of we had to move quickly and throughout our work, we provided advice based on what we knew at the time. Our product was advice letters. So we wrote advice letters that we then supplied to the Minister of Health and the Minister of Industry, Science and Economic Development. And so rather than have a glossy report along the way or at the end of it, there's many, many advice letters. There might be 40 of them now on very specific issues. The science rules the day, that's interesting. And my panel members and others will be able to explore this better than I. But we tried to follow the science and not let politics and other things get into it. So we would make our decisions based on the science that we knew. I think this has been an ongoing issue and has had a somewhat negative connotations in the sense that the science is evolving so quickly. It depends on, and people are talking about science by press release versus clinical trials and so on. I think the difference is when we are following science rules today, we're making decisions based on what we know. Some of the questions that are being asked by people to evaluate take time. And any of the time-based questions are very challenging, such as duration of protection. One does not know the duration of protection till the time passes. Same with potency. I know there's been discussions about the AstraZeneca was expiring on May 31st. Now it's extended to July 1st. People start talking, that's like milk. Well, really what it is the assay is done at a point in time, and depending on the potency of the antigen, that's how long it's effective for and safe for. And we won't know if those lots have another 6 months dating till 6 months go by. So happy to talk about that a little bit further in the Q&A if need be. Third, just very briefly on the results. So 4 vaccines approved in under 18 months. Unbelievable. It's been a terrible year for the disease. It's been a remarkable year for vaccinology. If I was a betting man, well, I had all 4 scenarios in what I referred to. I probably would not have bet on that one. So it's wonderful. The vaccine rollout is underway. Steady wins the race, tortoise and hare comparisons and other things. There are still many scientific and research questions to be addressed. And if I think about it, for me, communications challenges in an ever-changing complex world have really been an issue and for things to deal with. People seem to want instantaneous perfection. They want instantaneous answers on questions right away. Some days I would be watching the national news. It's like what I did for a living for the past 33 years is actually on the national news, and everybody's watching me work. When you get to things like timing of deliveries and supply issues and challenges and potency issues, all of that, which was fairly routine to deal with in the industry, has now been exposed, and it's clear why. I mean, this is such an important pandemic to deal with. Everybody's very interested. And then I'll just finish with one topic: the future. And again, my fellow panelists will deal with a number of these other issues that we've just touched about. But so there will be future pandemics. How will we respond? And that's a whole other topic that we can again spend anywhere from 5 minutes to 2 hours on. So Terry, I will stop there. Thank you very much. It's great to be with the group, and I look forward to the rest of the session.
Thank you very much, Mark, and thank you for being on time. Just to note that with respect to the format here, we're going to go back to back with each of our guests to do their presentations, and then we will open it up for Q&A. And really the chat is just for comments. I'll try to kind of cull together a number of questions based on what goes into the chat, and we'll try to then have open question and answer with a good solid half hour at the end, or slightly more if we're lucky. So with that, thanks again, Mark. Let's turn it over to Vivek Goel.
Thanks, Terry. And it's great to follow Mark on this, as I did a year ago. And, you know, both he and I made the same mistake in saying it's unlikely we'll see a vaccine in 12 months to 18 months. And, you know, we had trials starting, literally, I think they were starting a few weeks after or around the time that we did that webinar a year ago. But as I followed Mark and I talked about some of the challenges that we were going to face in more depth, and certainly we have faced those. And I'll elaborate on that a little further today. Just a word about my background, which I put up last year as well. For those of you that may not be familiar, this is the Fitzgerald building, which was the headquarters for Connaught Labs, as well as the site of the original School of Hygiene, which is now the Dell School of Public Health. And it's a reminder, as Mark noted, that we have some great Canadian expertise in this area. So I'm going to start with the messenger RNA success story. And, you know, a lot of people, and Mark reflected on how fast this has evolved. A year ago, this was new technology that we were very uncertain about. I just want to say a few words about the people behind this, because their story have not been told as much. And we often forget about the fact that something like this has actually taken decades to develop. And Cataline Carico, who here is pictured and is now a vice president at BioNTech, the developer of the vaccine that we actually refer to as the Pfizer vaccine, was a Hungarian academic, had ideas that were seen as on the fringe, and never got a permanent academic position. Her grants were consistently turned down. But she was the one that persevered with these ideas that led to the development of these vaccines. Derek Rossi is a University of Toronto undergraduate, not your typical academic here, as you can see his shirt pictured, and went on to be an academic at Harvard and one of the co-founders of the Moderna vaccine. And Kazmika Corbett, whose story has not really been told, is an immunologist that was working at the NIH last year that led some of the early stage phase 1, phase 2 trial work on the Moderna vaccine. And as you can see from this headline, has gone on to be essentially a role model for the Black women in science, but also has really done a lot of work to address vaccine hesitancy, concerns about experimentation that are quite legitimately expressed by the Black community. So I introduced with that just to say we should always pay attention to the people behind this kind of work. And also, to me, this also reflects the importance of diversity and inclusion in science, and making sure that as many views as possible are brought in, because otherwise we don't get the kinds of breakthroughs that we've seen with these vaccines. Now, I want to pick up on the science rules the day comment. Certainly I very much would like to see science ruling the day, but as Mark said, we have to work with uncertain science. We have to work with rapidly evolving science. We have to work with conflicting science and conflicting views. And that's the reality of the scientific method, right? We don't get to immediate consensus. Catalina Carrico's ideas were not accepted for decades. And this sort of stuff happens in the journal pages, back and forth, letters to the editor, or at conferences and discussions. What we've seen play out in the last 16 months is science playing out in press releases, in blogs, and in social media. And so the public has been exposed to those conflicts, and it's perhaps led to a lack of confidence in science. But the other thing that I think is really significant is that science does not on its own lead to policy. Science informs policy. And so when politicians say that our decisions are based on science, they should really be saying that our decisions are informed by science. Public health officials bring in a number of other considerations, and I'll highlight those in a second, into making their recommendations. And then ultimately, politicians make policy decisions incorporating values and perspectives and voters and a variety of stakeholders. And we have to recognize that. And so that's going to lead to different decisions being made at different points in time by different people. And so it's not unusual to have the diversity that we see. But what we need to be able to do is to explain why the decisions are different. To say, here's the science we listened to, and here's how we wound up with this different decision. And that, unfortunately, is something that our political leaders have not been doing very effectively. I don't have time to go through this chart in detail, but Mark referred to the task forces and so on that were created. Again, we think that science is getting generated and decisions are getting made. But science is influenced by what gets funded. And we've seen an incredible amount of research funded in sometimes haphazard manner or discoordinated manner. And then we have a variety of bodies that actually help in that interpretation, because the people in the decision roles can't be listening to the science all the time. And so during COVID, we have existing bodies and we have many new bodies. And so one of the challenges we faced is not only is we have rapidly evolving conflicting science, we have many different groups presenting on that science. And so we had reference to NACI, the National Advisory Committee on Immunization, Health Canada, the regulator. They play very different roles, and that's just two of the bodies that are there, right? The regulator is there to determine that the vaccine is safe and it works, and they look at a single product at a time. NACI, the National Advisory Committee on Immunization, has to make policy recommendations to the federal government, the provinces and territories, who then decide what to do with them. And so they recommend on the strategies, and they have to consider things like supply. They have to look at the different vaccines that are available versus Health Canada's looking at a single vaccine. So there's many other considerations that NACI has to incorporate their group of volunteers and put forward an advice to the minister. And so when one is saying it's safe to use in all ages, which Health Canada has done, and then NACI saying not safe to use over the age of 65 back in March for AstraZeneca, it's because they're looking at different elements of the science. So they're both following the science, but they're looking at different aspects. And then in terms of coordination, and I know Jeff will probably talk about this a little bit further, one of the positive things that did happen late in the fall is the Vaccine Surveillance Reference Group was created, which brought together several of the key bodies that were charged with doing surveillance on the immunization rollout. And so that's actually been a positive. So we have been learning as we went along. So why is the science so different? The studies that might get reported, phase 1, phase 2, are going to be looking at biological endpoints. In the clinical trials, there's a whole range of endpoints that can be examined, from cases of infection, asymptomatic or disease, through hospitalization and death, and then looking at actual prevention of transmission. There's the evidence from the trials, and there's the evidence in the real world, the efficacy versus effectiveness. So when people are throwing around numbers, this vaccine was 70% and this vaccine was 80%, if you don't actually go back and look at what was being measured, in whom, what ages were in that trial or in that real world study, what populations, did they have comorbidities or not, what were the variant strains that were circulating at the time that that study was being done, the comparison of one vaccine to another by headlines or social media is not really appropriate, but it certainly leads to a lot of confusion for the public. Then there's the safety signals, which we knew were going to emerge. And I talked about this last year, that we have to be ready for the fact that once we start to immunize millions and millions of people at the same time, we will see events happening. Jeff will, I'm sure, touch on this further. Some will be by chance, and some will actually be related to the vaccine. It's going to take us time to figure out which is which. But all of this gets melded together with all this evolving data, and of course, it will lead to confusion. And so it doesn't help, but it is certainly expected, based on what I've described, that we wind up with these situations where we have very different opinions being reflected. Mona Nima, our chief science advisor, saying that the extended dose interval was a population level experiment on national news, and our public health officials saying that's the way we're going to have to deal with our limited supply and the impending third wave back in March when these decisions were made. A few words very quickly about the logistics and the rollout. And here I'm showing the percent of people that have received one dose of vaccine in Canada. You can see it extending, going up really fast because of that first dose fast policy, and the percent of people, or the number of people that got the doses per 100,000. And despite the headlines that Canada's a laggard and so on, we're certainly doing well on first doses, but that's part of our policy. But we're doing very well on doses per 100,000 or per 100 people. We have a few countries that hoarded the vaccine or sold their population's data in order to get faster access. We're doing well relative to the European Union, and we really have to think very hard about what's happening in the parts of the world that haven't had the access to the vaccine that we have had, or that some of these other countries that hoarded vaccine have had. And I'm sure we'll come back to that in discussion. Mark touched on the logistics challenges, so I won't go through these in detail, but just remind you, 200 components into the Pfizer vaccine. Delivering vaccine, maintaining cold chain, from getting from the manufacturer to thousands and thousands of sites, primary care, pharmacies, hospital, clinics. What it takes to actually manage this program in a country with so many levels of government. So again, we shouldn't be surprised by the logistics challenges that we've seen. And then the fact that it's not just the vaccines that we need to actually deliver them, hundreds and hundreds of supplies for every single clinic. And Mark touched on vaccine hesitancy. And the great thing in Canada, and this is data from mid-April from Angus Reid, 82% of people have had or booked their appointment or committed to getting it. That number is actually approaching 90%. So we're not seeing the plateau, if you saw the graph from Israel, where they peaked out at 60%. And that mushy middle has basically been going down over time. And despite all of the controversies and so on, the level of confidence in the mRNA vaccines is quite good. It's gone down for the Janssen vaccine, which is still not available in Canada, and it's fluctuated for the AstraZeneca vaccine. So we do have to watch what's going on, but certainly the level of confidence in the workhorse vaccines that we now have remains very strong. So thank you.
Thank you very much, Vivek, for those comments. Once again, just folks, remember, if you want to put stuff in the question and answer, we'll try to deal with that going forward. So, Jeff, onwards to you.
Great, thank you. Yeah, I'm impressed that Mark and Vivek remembered what they said last year. I actually have no recollection of what I said at last year's session. All I remember was my internet kicked out on me in the middle, while like mid-sentence. So thank you for the others for filling in while I was trying to log back in. Anyway, today I'm going to be talking about COVID vaccine surveillance. So some work that's underway and some work that we've completed already, looking at various aspects of COVID vaccine surveillance. To start off by saying I have no financial conflicts of interest to disclose. And so this is just a quick list, a very brief list of some surveillance activities that can be done. You know, Vivek talked about, confidence. I'll talk a bit more about coverage, safety, and effectiveness. And then obviously, eventually we'll have to look at the vaccine program impact and evaluation. But today I'll just be mainly focusing on these three, given the time constraints. Okay, so the Canadian Immunization Research Network is a network of networks focusing on immunization research, obviously in Canada. It was created in 2015 through funding from Public Health Agency of Canada and CIHR. And one of the networks that I co-lead is the Provincial Collaborative Network, or PCN. And we use databases from various provinces to do vaccine research and evaluation. And so with COVID-19, we were able to obtain funding from CIHR and from this vaccine surveillance reference group through funding from the COVID-19 Immunity Task Force to conduct a post-market studies of COVID-19 vaccines. So we've got 5 provinces participating. Today, I'll only be talking about data from Ontario, but hopefully in the future, we'll be able to mount some multi-provincial analyses so that we can maximize our statistical power to look at these issues in rare populations. Okay, so this is just a schematic. I know it's a very busy slide. Just to show an example of the data holdings at ICES. That's the institution where I do my research. And so we are a not-for-profit research institute where that houses all the health administrative databases for Ontario. And so it starts off here in the middle with this registered persons database, which is essentially anyone who's ever had provincial health insurance in Ontario. And we can link using the encrypted version of the health card number to all the other health administrative databases. So anytime you go see a doctor or get hospitalized or go to emergency department, it's captured in the database and we can track people's trajectories in their healthcare use. Now for COVID-19, we've also linked, this is the laboratory testing for COVID. This is the public health surveillance data set. So all cases of COVID-19 are recorded in this CCM database. And then the COVAX-ON is the COVID vaccination registry. So we can link across all of these databases to do our research studies. And we can identify people with various comorbidities, and all that. Okay, so now I'll talk a little about vaccine coverage. So, we know that the pandemic has had an uneven impact. So there's people in certain areas have been more highly affected than others. And so this is just a map done by colleagues, mainly out of Public Health Ontario, and it was published through the Science Table that looked at the incidence, the cumulative incidence of COVID-19 infections across Ontario. And you can see the red, there's a lot more here in Peel, in certain parts of Toronto. It's high incidence of COVID compared to other parts of the province. And so these are at the level of FSA, or the forward sortation area. Basically, it's the first 3 digits of your postal code. And so there's more than 500 FSAs in the province. And what they did here was they ranked them into deciles. So they grouped them into 10 buckets across the bottom here. So, these columns, each column is 1 decile. So number 1 is the highest risk decile. That's where they've seen the highest incidence of COVID-19 infections. And then they've stratified them by age group, which are the rows here. And this grid is actually showing the rates of deaths or hospitalizations per 100,000 people. And so we all know that, people at higher age groups are at higher risk of death or hospitalization. And it makes sense that areas where there's higher risk of COVID, there will be higher risk of hospitalization or death. So you can see in the upper left corner here, really high rates of death or hospitalization from COVID. And then it kind of goes down as you go from left to right. And then it also goes down as you go from top to bottom. But what's interesting is that at the very bottom left corner here, the rate of death or hospitalization from COVID is actually higher in this young age group in the high risk areas compared to the oldest people in the low risk areas. So keep that in mind as we go. So there was kind of like a recommendation that we should really be focusing on these high incidence areas or hotspots for vaccination and not just go by an age-based recommendation. So this is a busy slide, but I'm just showing you, this is a vaccine coverage by neighborhood risk. Taking the work that was done by the Science Table, we were asked to look at vaccine coverage using the ICS data, where we linked the where we were receiving weekly feeds of the COVAX data, and then looking at it by FSA. So what we have here is the same thing, where we have the neighborhood deciles in high incidence here on the left, and then low incident on the right, and then broken down by age group. And so this was, as of March 29th, you can see that there was actually higher coverage in the low risk areas, especially in the older adults, compared to the high risk areas. And overall, it was 13% coverage of all adults, from 16 and older. And it was this that led to the province announcing the hotspot strategy. So where they were, planning to try to direct more doses towards the hotspots. And so that's, defined as, deciles 1, 2, and 3 was what, how the province defined it. And so you can see by April 12th, you can see starting, more green in the left-hand side. And then by April 26th, 2 weeks later, you can see more and more green. And then by May 10th as well. So you can start seeing by May 10th here, or even earlier, but the coverage in these high-risk deciles is actually higher than in the low-risk deciles overall. And then you can see the latest data available as of May 24th, and now we've added another line for the 12 to 15, but you can see it's like a lot more green, 80-something% in all the older age groups, even 70-something%, in the middle, 60-something% in the middle ages. And so we're just getting up there. I think we need to continue, we're done quite well in these hotspots areas, 60-something% overall. And then, I think we just need to continue this and, start vaccinating these 12 to 15. This is for 1 dose at least. And then we're also starting to track 2 dose received, like the coverage for those who received 2 doses. So this is just an example of how data have, informed our policies by trying to get vaccines to those areas that need it the most. Okay, now I'm going to talk briefly about vaccine safety. There's a lot of work that's going to be needed in this area, as alluded to by Vivek. This is one study we did quickly where we looked at background rates of adverse events of special interest. That's what this AC acronym stands for. And we looked at selected thromboembolic or coagulation disorders. So right after the whole VITT situation, kind of became known, and this is before we had a very good understanding of it, we looked at, what were the background rates of these, in terms of hospitalizations and emergency department visits. And so you can see that, we looked at the 5 years before the pandemic, 2015 to 2019, in the administrative data. And you can see that for each of these, sort of conditions that involve blood clotting, you can see, various rates, incidence rates per 100,000. So you can see, ischemic stroke is far more common than these rare cerebral venous thrombosis. That was one of the types of the VITT blood clots. So those is probably a totally different mechanism, but sort of the same location where we're seeing a lot of the VITT cases. In terms of vaccine effectiveness, this is something that we're working on very actively right now. This is a preprint that was just posted on Friday, looking at vaccine effectiveness of the mRNA vaccines in Ontario. And so I'm just sharing just a couple of figures from this paper. And we were using the test negative design. This is data only up till April 19th. We're in the process of updating that right now, and hopefully have some more recent data to share in the coming weeks. But this is looking at, we looked at symptomatic infection as one of our outcomes, and our second outcome was looking at severe outcomes. So that's hospitalization or death. And so what we did was we looked at, the test negative design is simply, a variant of the case control study. And we looked at, at the time that you got tested for COVID, how many doses of vaccine had you received? So out of like the 325,000 so people who were tested and had symptoms of COVID at the time of testing, we had about 50-something thousand cases, and we were able to estimate these, come up with these estimates of vaccine effectiveness. So after one dose, you can see that, by 14 to 20 days, it's about 50%, then it goes up to 60%, then about 70%. So it kind of goes up gradually over time. And then after 2 doses, it's very high at, 90-something%. So 7 days after 2 doses, it's about 90-something% effective in preventing symptomatic infection. And then similarly for severe outcomes, we see very high vaccine effectiveness after 2 doses, but after 1 dose, we actually see, after 35 days, it's actually surprisingly high as well after just 1 dose. So I think this reinforces the decision to go with the first dose is fast strategy. Let's get as many people 1 dose as quickly as possible. At least they'll have partial protection. And the most important outcome is the severe outcomes. And it appears like they may have a very good protection against severe outcomes. We've also looked at, as part of this, we looked at VE against some variants of concern. And so this was before the B1617 variant that was originally identified in India was around in Ontario. But we looked at the B117, and which was originally from the UK, and then the B1351, which is from South Africa, combined with the P1 from Brazil. And so you can see that this is a symptomatic infection. So after 1 dose, similar VE for the B117 compared to the earlier variant, and then maybe slightly lower for this combined B1351 and P1. But after 2 doses, we have actually very high VE against all 3. And then against severe outcomes, again, high VE after 2 doses, and very wide confidence intervals here just because we had very few events. So this is something that we're actively monitoring, and we're hopefully going to be able to add lines here to look at the B11617, the next time around. And also we're going to be looking at, vaccine effectiveness of the AstraZeneca vaccine and longer intervals since each dose. Oh yes, sorry, couple more slides here. Just to show that what we did was we looked at it stratified by age group. And you can see that, in the younger age groups, we have very high VE after 1 dose, pretty soon after receiving 1 dose. But then in the older adults here, you can see that it takes time for them to get decent vaccine effectiveness. So by 28 days, this is about 60-something%, but before then, it's only about 24%, 40%. So that's something to keep in mind, that our older adults need longer time to get good VE, but they do eventually get to decent VE, if given enough time. Okay, so I think that's it. I just wanted to acknowledge there are many people involved in this work, and I just want to be happy to answer any questions during the Q&A session.
Terrific. Thanks, Jeff. That was a terrific presentation. So let's move directly into Jennifer. Jennifer. Ready to roll?
I am, and thank you and welcome everybody. I'm so glad to see such a large number of folks on the line today, and I'm really grateful for the invitation to join the panel. So I'd like to build on some of the reflections that have already been shared by Mark and Vivek and Jeff, but then again push these a little bit further. For those of you who don't know me, as Terry introduced, I'm the director of the Joint Center for Bioethics at the University of Toronto, but also during the pandemic response, I've had the honor and the responsibility of being co-chair of the bioethics table, providing advice to government. And so, you know, really, it's been a long journey, as it has been for each one of us, in learning what it means to respond to a pandemic through each of the roles that we may play as citizens, as community members, as academics, and then as advisors, as the case may be. And in preparation for today's webinar, I didn't participate in last year's, so I took the time over the last several days, just to reflect back on where we were on June 2nd, 2020, as a system, as a society. And so I went back to my notes from some of the COVID related meetings I was a part of, and also took a peek at some of what was going on in the media at that time. And on June 2nd, 2020, Ontario had passed the apex of wave 1. It was on sort of the moving towards perhaps a more promising summer at the time that many people were thinking. Case counts were down, testing was up, hospitalizations and ICU admissions were also declining, and as were deaths at that time. And all of these were seen as positive signs that perhaps the acuity of the crisis, at least for that particular wave 1. The possibility of a summer, the possibility of lifting public health measures, the reprieve from the intensity, the uncertainty, and the anxiety of the preceding months was something that was sort of on the tip of people's tongues, and certainly in their hearts, at least for some of us. And there's this cautious sense of optimism and relief that maybe, just maybe, the worst had passed. But when I looked at my notes more carefully, there was a different story that was starting to emerge, and it was about the human impact of the COVID pandemic. The impact, not just simply in terms of, as I described, some of the healthcare indicators that had surfaced, but the human impact as well in terms of, for example, the impact on long-term care homes, staff, residents. Many of the public health measures that had been introduced had led to not only sort of measures intended to reduce transmission and to reduce, to prevent death and to prevent morbidity, we're also having profound human impacts in terms of people's social connectivity and social relationship. And this was especially felt in long-term care homes, many of which were experiencing outbreaks at that time. And in those early weeks of June, as there was a redoubling of effort to aid long-term care homes, in terms of, and also to start thinking about planning for a possible wave 2, concurrent with this, and let's keep in mind too that in the previous week, we heard the shocking news of the death of George Floyd and of Regis Korchinski-Paquette. We started to hear and we started to see increasing evidence emerge that, in fact, as Jeff was pointing out, the impact of COVID was not being experienced equally. That there were some communities, particularly racialized communities, were disproportionately affected by this. There were neighborhoods, particular neighborhoods that were seeing higher cases of COVID, higher deaths. And if we looked underneath, we looked at the people living in these communities. It was becoming increasingly clear that there were socioeconomic and other structural and systemic factors that were contributing to that, to the vulnerability of these neighborhoods. Now, it's important to point out too that we can talk about vulnerable populations, vulnerable communities, but it's really, I think, what we want to be looking at, what is the vulnerability of the conditions that the conditions create. And so by June last year, this was becoming it was visible, and it could no longer not be seen in our response. All June 2020, there was no vaccine in sight. So where does this leave us? And so this is where I want to leap forward to where we are, how we got from June to now. We've already heard a really wonderful canvas of steps that have been taken from my colleagues on the panel. And I think just as a general observation, we can think about this as a linear process, and that's the way history is often written, as if it's linear. But in fact, I think as we started to hear from some of my colleagues on the webinar, there were various moments moments where there needed to be a shift in approach. There were lessons being learned along the way. It was an evolving context. And so I often heard it said, we are, in effect, we are building the ship while sailing it, or building the plane while flying it. And this continues. And it's challenging, I think, for many of us who may find ourselves as decision makers or may find ourselves as academics. And we know that we often draw on science, and we draw on governance structures, and we draw on reliable sources of authority to help make decisions in a pandemic when a lot of those rules are thrown out the window, and we're trying to figure it out as we go. And so one of the things that we have in Ontario is partly as a result of SARS and the profound lessons learned then, and subsequently in preparation for in the lead up to H1N1, there was a great deal of experience and thought that it had been undertaken in the province to help inform a pandemic response. And yet there's nothing like the real thing to really underline what we don't know and what must be worked out in practice together with others. This was an all hands on deck type of crisis affecting each one of us. Now, one of the things that I want to pick up on, Mark said about science ruling the day, and I know Vivek also picked up on this as well, was on the one hand, we've seen this sort of resurgence of confidence in our scientific community, and looking to science as a guidepost for some of the thinking behind policy choices. And yet it's as also noted that science was evolving, and we're learning constantly as new evidence emerges within our own province, but also learning from other health systems as well. And so there is this empirical uncertainty with which we've been grappling with along the way. And yet, nevertheless, decisions needed to be made with urgency, and so with sort of a keen awareness of the uncertainty of those decisions. And so this is where science rules the day, but I think there are two other elements that I think are worth keeping in mind here. One is that in the case of empirical uncertainty, what do we draw on? We can certainly draw on politics, but ultimately when we're talking about politics, we're talking about people, we're talking about values. And so we started to think about what are the values that ought to inform our response in the face of such empirical and indeed practical uncertainty. We draw on the values that hold us together, the values that we might point to as a commitment to trust, to minimizing harm, to transparency, to a sense of solidarity of communities coming together. And I think we saw a lot of examples of communities coming together, whether it was clanging of pots in the early days of the pandemic, or communities mobilizing together themselves to make testing and vaccination accessible to those who were having difficulty accessing testing and vaccination within particular communities. So we had values to draw on, but we also, I think, we've learned along the way as well that this is a pandemic response, is not a government response. It is not a top-down response, although often we appeal to a command and control type of structure for these decisions. But I think a lesson that we may have learned through this is, in fact, good governance in a pandemic and a good response is one that necessarily has communities as partners in the response, not as simply being engaged into a government response. And so these are some of the valuable lessons that have been offered to us, the role of communities, which is core and essential to an effective pandemic response. Which leads me to two final reflections before I close off my comments. One is the ways in which, as we listen to the ways in which the vaccine hesitancy has been talked about in the media, perhaps, or at some of the tables where some of us may have sat, or in the communities we may find ourselves. I think Vivek's, the data that Vivek shared with us is the extent of vaccine confidence, in fact, there is. And so sometimes the problem of vaccine hesitancy has been one that I've been hearing from some communities has actually masked what is fundamentally an access problem. The problem is not hesitancy in accessing vaccines. You might look at particular communities or neighborhoods with low vaccine rates, and it's simple, and very simplistic and unfair ascription would be to say, well, there's hesitancy there. When in fact, it was not that at all. It was access. Making vaccination, as with testing that accessible to those who need it, where they need it, in ways that makes it possible for them to take advantage of this, something which all of us should have access to. And I guess another picking up on a lesson that I learned from my colleague Caroline Lidstone-Jones in something that she said in a presentation about vulnerability is a label. To really point again to the importance of us thinking about the human beings and the conditions within which they find themselves, which means to talk about vulnerability creating conditions, and really then to begin thinking about how might communities bring their strengths to be able to, and with support, if it's needed, to be able to reframe, to recondition those conditions within which they find themselves, and in fact to actually recreate those conditions in a way that fosters social justice as well as good health and well-being for all. And then finally, my last reflection on it, and something that Mark had picked up on, and others, and Jeff has as well, about some of the importance of ultimately this is a societal experience that really calls on levels of public trust. And I think in many ways we take trust for granted until we face moments of uncertainty such as this. And so we have an opportunity as we think forward to where we may wish to be on June 2nd, 2022, how we might be able to carry some of these lessons forward to imagine what a resilient health system, what resilient communities, what a healthy, resilient, and equitable communities may look like that is founded on a solid basis of trust. So perhaps, Terry, I will just leave those reflections there and leave, it seems, lots of time for us to be able to have conversation with everyone else who's joining us today.
Terrific. Thanks so very much, Jennifer. Most appreciated. So maybe we can dive in onto a number of questions. We've got a number of questions that have been put together in the question and answer area. First one I registered was, what about the issue of mixing vaccines? Starting with one and finishing with another. And so who would like to take a shot at that?
I can start. Terry, I'd be happy to start. So I'll talk one aspect of, so mix and match, and there were some comments made, we've done it before. And when I saw that on the news, my first reaction was, we have? Not very often. I mean, maybe somebody could point out the exceptions that I'm missing, but in the past, and I was involved for 33 years, when we mixed and matched in the past, it was generally because we had supply issues or challenges to overcome. And so I was thinking, I would like to hear what some of this was. I mean, that's different from saying mix and match now, because there's all sorts of reasons why we will, but to say we've done it in the past so we can rely on that, I was thinking, I'm not that aware of many examples. I do recall, and I then later heard somebody talk about hepatitis A, and I do recall some examples of hepatitis A, but those really were when we had supply issues, when we'd have 2 or 3 suppliers, and 2 of them would be out of supply. And so there was really one supplier left, and you could either mix and match or you wouldn't be vaccinating. Another example I heard was flu. Well, flu is really, I mean, you're not doing boosters. It's one dose once a year, and every year you start off fresh, and everybody is relicensed again, so you get to choose. So I'm not sure that we've had that much experience in the past. I think it does go to the point that the supply of vaccines is really challenging. In many ways, the challenges that we've experienced this year, I would say, are far less than expected. We have challenges with traditional vaccines that we've been making for 20 years. So mixing and matching and the data involved and the need to do it and given supply, certainly that's something that is there. But in terms of the question around, we've done it in the past, I'm not aware of that many examples.
Thank you, Mark. Others want to jump in here? I know that we have a...
Yeah, this is Jeff here. I was under this understanding that that HPV vaccine, that they are able to use different products as one example, and maybe also like hepatitis B vaccines. I think there have been other vaccines where mixing and matching has been approved. So I would say
so when they were, they're usually, you know, it goes back to that time-based science that we've had time to look at these things. So it hasn't been done. I mean, those would be very specific examples. I know when we looked at, you know, the pertussis-containing combination, it took some time to get there. People wanted to do it, but it wasn't just a natural thing. Mm-hmm. And I would add, not to take away from the mix and match and the studies and the recommendations. I mean, that's all valid, and it makes sense to follow that data. I just was saying it wasn't that common in the past.
Yeah. Okay.
I just add, Terry, like it also wasn't common that we had, I can't remember what the number was a year ago. There were 90 vaccines under development, and we wound up with 4 approved, right? We haven't normally launched mass immunization campaigns having so many different vaccines available to work with. So it's not just a question of has it been tried in the past, it hasn't actually been possible that often in the past either.
Yeah, so there is a note by Kathy Bowie in the exchange here too about circumstances where AstraZeneca and mRNA were strung together. So again, I don't know, and Vivek or Jeff or Mark, your thoughts on this. Is there any value or merit in looking at, for example, even trials or, you know, studies to look at how these different vaccines interact?
Maybe I'll just start off, and Mark or Jeff might add in. So first of all, there was a study announced about a week ago, led by Joanne Langley and Scott Halpern from the Canadian Immunization Research Network. That's going to be a Canadian mix and match study. It's going to look at different dose intervals, as well as every possible combination of every vaccine approved in Canada. The reality is the results of those studies are not going to arrive in time to inform the decisions that have to be made like this week or be made now. But it's important because it will, you know, following the previous discussion, it will add to our knowledge base for the future about what is possible in these sorts of situations. We have some data coming from other jurisdictions. Kathy, in an earlier comment, referred to the Spanish results, which are largely what informed the NACI statement yesterday. There's a UK study as well that's partly reported with its side effect data, and will be reporting effectiveness data sometime in the next week. I believe some of the results have already been presented to the public health authorities from those studies, and there will be other results coming out. So again, this goes back to the point that Mark and I made. This is science in real time, right? The vaccines have only been available for about 8 months. You know, if we want to talk about dose intervals, the first people are just coming up to 16 weeks. So in terms of having data on what happens at 16 weeks, we'll start to generate that in the coming weeks and months.
Thanks, Vivek.
But again, just to emphasize Mark's point, that doesn't mean the decisions haven't been based on science. They've been based on the immunologic data. They've been based on the projections that are possible. And so they've been informed by the science, but in terms of the hard evaluative type of data, the kind that Jeff was presenting from vaccine efficacy surveillance, would need to have further follow-up time in order for that to happen.
Thank you. Jeff or Mark, do you want to weigh in on any of this?
Yeah, so I mean, just to build on what Vivek said, and I didn't mention this during my presentation, but we are, PCN is working with other provinces, and in Quebec and BC, where they went to delaying their second dose, from the beginning of their program, there's going to be more data from those provinces on like VE 16 weeks. So, we're working with them, and hopefully we're going to be able to come up with good estimates for, that 12 weeks, 16 weeks, and see how well the vaccine is still working, to see if it's, starts to decline. And then we're also going to be following up over time, how long, let's say it's like 6 months after you receive your second dose, what is the VE? Is it still good? Do we need boosters? When will we need boosters? So it's all these sorts of things that, as Mark said, we can't really answer the question until we've had enough observation time. And, at this point, all we've got are the trials data, the people who were vaccinated last summer in the trials, and they're probably being followed up now, but we'll see when we get more data on like the need for boosters, for example. And
Terry, I
think,
guess.
oh yeah,
Oh,
sorry.
sorry, Jeff, go ahead.
Oh no, go ahead, Jennifer. I was just going to move to another question.
Yeah, so I guess what comes to mind for me is that you know how this really ties back into communication around science. Some of the science and some of it is here's what we know, here's what we don't know, and then here's what is unfolding, and sort of keeping that, like ensuring that that transparency is there, but also that it's well understood. And I'm also thinking in particular about if I am going to see my GP, I may have questions about mixing. I may have like, what are some of the guidelines? What does this mean for me? And I'm thinking this is where it's not just for public communication, but it's also those key partners in someone's care, which are your frontline provider, your GP, your nurse practitioner, your community health center, and so on. That we also need to keep in mind in terms of providing assurance for them so that they understand the state of affairs, so that they can most effectively communicate with citizens, the rest of us who may be asking the questions.
Yeah, that's a really good point. You know, I work as a family doctor as well, and it's really hard, you know, for providers to keep up with everything. It's such a dynamic situation. And so, you know, when I was vaccinating at, you know, a pop-up clinic, and people were asking me, oh, when am I going to get my second dose? And I said, well, just watch the news. You know, it's like a really evolving situation, and just keep your eyes and ears open, and then you'll find out when you can be eligible for a second dose. It's probably going to be sooner than 16 weeks. That's why we didn't even bother scheduling a second appointment for people.
The only point I would add, Terry and colleagues, is I think it gets to the communications point. This is one example of communications. Subtlety is so important. The messages are subtle, but they completely get lost because everybody wants black and white, yes and no, but it's subtlety that's behind so many of these things.
Thanks, Mark. A very interesting question, which I've heard several times now in other areas, which is what is the safety of these vaccines for pregnant women? From Masoon in the question area.
Yeah, I haven't seen any safety concerns in pregnant women. I think there was a paper from the US a few weeks ago, and you know, they were monitoring, I can't remember how many, like tens of thousands of pregnant women who received vaccines. They didn't see any greater risk of any side effects compared to the general population. So, I mean, we know for sure that the pregnant women are very high risk of serious complications. They're more likely to end up hospitalized in the ICU than non-pregnant women. So I think, you know, I know that a lot of pregnant women have a lot of concerns about any, you know, sort of, you know, external medications or vaccines during pregnancy. But I think this is one time where the risks are definitely outweighed by the benefits of getting vaccination. You know, unless you're, you know, especially if you're working outside the home where you could be exposed to COVID, it's really important to get vaccinated. I mean, if you're able to stay at home and have no contact with anybody, then maybe you can make the case, you know, for your whole pregnancy, you know, that you can get away with not getting vaccinated. But yeah.
Terry, if I could just comment on this, and maybe Jennifer will want to respond to my comments. Like normally, again, when we're doing vaccine development and evaluation, you spend 7 years or whatever it is. And so you start with your trials in healthy adults, right? And you exclude your older population, you exclude people with chronic conditions, you exclude pregnant women, you don't look at kids. In the middle of a pandemic, you know, those are the populations that are most vulnerable, that are most at risk, but they're left out of the trials. And you know, you do it sequentially because you first establish safety and effectiveness in those, in the sort of the least vulnerable populations, you move your way out. And you know, probably we need to think about in future pandemics, does that make the most sense, or should you actually design your trials to work with the people that are most likely going to need the vaccine earliest?
Yes, to pick up on Vivek's point, I mean, I think what we're confronting is an evidence building moment, right? It's not this, and so this is where we're going to be learning with those who actually take the vaccine. And in fact, recently I was vaccinated, and I think everyone now is invited to be part of a study to be able to track this, to be able to understand this unfolding, the unfolding of this. But it does raise an interesting question about how we might be able to think about the design of studies, the design of vaccine studies that would actually sort of embrace the diversity of potential users of a particular vaccine. I think it is going to be, there are certain risks associated with doing so. I mean, by virtue of the nature of some of those subpopulations, pregnant women, children as examples. It does, I think, also invite another question, which is under these conditions right now, where an individual and their family may be trying to make a decision about whether or not to proceed with a vaccine or not to proceed with a vaccine. It's on balance of risks. And so it's also thinking about how to support individuals and their families to make decisions that make sense for them in that moment, where in fact, they're going to need to live with that risk assessment. And so whether it's to take the risk of preventing infection by virtue of the workplace where I work and I happen to be pregnant and I'm concerned about that, on balance with the risks associated with potentially contracting illness and then finding myself very sick and potentially needing intensive care. So really supporting individuals and families to be able to make those decisions is as much part of how we manage uncertainty and also provide, demonstrate that under these conditions, we appreciate the limitations of what is known and what assurances can be offered.
Very good comments, Jennifer. Thank you. We have a question here, which probably a number of people might pipe in on, but what is the prospect for homegrown vaccines within our country? So I know that there is some discussion in Quebec, and Mark or others, do you have any kind of insight on this?
Yeah, I've spent a fair bit of time on this. A couple of things, and this, I mean, there's been a lot about biomanufacturing, homegrown vaccine, and the story of Connaught Labs and things. I would say, as I mentioned at the beginning, the vaccine task force. So we were the ones who recommended what vaccines the government should procure, and we looked at domestic candidates, international candidates, and biomanufacturing, and I've appeared before a couple of parliamentary committees and other groups, and made the comment that there was not going to be a domestic solution that was going to yield a vaccine that we could use in 2021, and or certainly maybe in 2022. And it's just a matter of where we're at there's a lot of assets that are out there. We tend to be smaller companies in biomanufacturing in Canada. There's progress along the way. The first Canadian-based vaccine will likely be Medicago. That's one of the 7 vaccines that we recommended based on the virus-like particle technology. They are now starting phase 3 clinical trials. The government has signed an agreement with them. There's other promising technology that has been funded, and the government has taken a look at biomanufacturing for the future. We have recommended investments to the government. They have acted on a lot of that advice. So there are biomanufacturing investments underway, and one would hope that they will be available, a Canadian solution, not in the short term, but say in the intermediate to longer term for this pandemic and future pandemics if the need arises.
Gary, if I could just build on that, and Mark is being modest. First of all, we have Canadian manufacturing capacity, and Mark led the company, one of the companies that had it, and we have the GSK in Quebec. It's been underreported or not recognized that we have vaccine capacity. It may not be the right type of vaccine, because certainly mRNA vaccines are new. Very few places had the ability to produce them. As I went through quickly, it's not just about having, first of all, there's the science base. So this question of, do we have the ability to develop or contribute to the development of vaccines? And we should really look at that, and part of the bioinnovation strategy that was in the federal budget is focused on that. We also need more capacity to be involved in the evaluation of the vaccines and running the trials, and the CERN network that Jeff is part of is there. But it's fair to say that we lag other countries in our ability to get the kinds of studies. The Joanne Langley study I mentioned, she's been working on that since January, and it was just announced last week. and the Spaniards are reporting the results. Like, we should be able to get these sorts of things up and running more quickly. In terms of having the actual manufacturing, and it could be licensing in and so on, it's one thing to say we can build the plants, and building the plants with time, we'll build the plants and so on. We need the personnel, and then we need the supplies. The Pfizer vaccine has said 200 components. We're not going to manufacture all 200 components in Canada, so we will always be at the risk of the global supply chains. And one of the things under the Trump bans in the United States, it wasn't just that they limited the export of the vaccines, they limited the export of the raw materials. And you remember the Indian Serum Institute begging Joe Biden to allow some of those raw materials, which the US no longer needed, to be exported. So even if we built our own capacity, we would still be in that situation of having to get the raw materials in if we didn't build up the capacity to do all that. And then the final thing, and again, Mark knows this really well, we can work really hard to get the plants. We have to buy the vaccines when we're not in the pandemic, right? Because global pharmaceutical manufacturers will put vaccine manufacturing plants where they think there's markets. And so what that really gets to, and I see a number of people on this that are in the health policy world, is that we have to be prepared to pay more for vaccines in non-pandemic times. And the deputy minister at ISED made a great point at a meeting. I think, Mark, you were at that meeting as well. He said, the Army has contracts to buy bullets in a war. They pay more per bullet to a Canadian manufacturer, right? Because you want to have those plants there, you want to have that capacity. And so other countries that have maintained their capacity, like the UK, invests in non-pandemic periods, essentially subsidizes the cost of production so that you can compete with the global marketplace. And if we don't do that, we're not going to maintain that capacity in the intervals. And it's a complex set of issues. We want to have the lowest prices possible. And our procurement processes that the provinces use will result in the lowest price going if it's equal effectiveness. And that might mean it's a foreign manufacturer that gets those routine contracts for vaccines. And then we will lose the manufacturing capacity. And that's essentially what happened over the previous 30 or 40 years.
Thank you, Vivek. So a good, very interesting question here from Alexis, which is really tied to hesitancy, but also ignorance and misinformation propagated by conspiracy or, people that are hardline anti-vaxxers. What does the panel think we should be doing to help support, engage, educate colleagues who have been misconceived or really don't believe in the whole science base? What can we do to what kind of campaign could be managed to ensure that we don't have a lot of disputes in this area?
That's a tough question. Does anyone want to tackle it, or should I jump in first? I think, there's really, vaccine hesitancy is something that, that a lot of people have tried to work on, and I don't know if there are any definitive answers. I think that what we do know is that there's not sort of one, like vaccine hesitancy is not one thing, right? Like there are the hardcore anti-vaxxers who are not going to be convinced to get vaccinated no matter what. And then there are a lot of people who are kind of like unsure and who could go either way. And then I think that's the population that we would want to focus our attention on, to educate them as much as possible, to listen to them, to understand their concerns. So I think you need to take various approaches. For some people, it's, concerns about effectiveness, and for others, it's concerns about safety. And for some people, they just want to, see that their friends are getting vaccinated, and then they'll go get vaccinated. So I think, definitely it's something that needs additional study and, time and energy. to try to get as many people vaccinated as possible. But I don't think it's impossible. I think it's, there are places where we're able to get like, 90-something% coverage. And I can see that happening for COVID as well, where, we've seen the harms of COVID. We know that this is a bad disease, and, there's a lot of potential, like a lot of health harms, like as well as economic harms from the virus. And so I think, not like it's not a good thing, but maybe one of the good things that we had such bad waves that, there hasn't been a lot of hesitancy here compared to other places in the world where, either there's a lot of hesitancy that's ingrained, such as the US, or in a lot of countries where they've had very, minimal impact from COVID, they've actually had a very hard time getting their populations vaccinated. And they're more fearful of the side effects than getting infection. But the reality is they can't stay closed forever. So I'm thinking of places like Australia and Hong Kong, where they've had very low coverage. Like we're talking about like 13 or 20% coverage only. And it's because there's no disease there. So people are saying, well, why bother getting the vaccine if there's no disease? Well, once they open up the borders, there will be disease. So they can't stay closed forever.
Thank you. I have an interesting question here being proposed with respect to whether there is any interest in studying the effects of vaccine on menstrual cycles. Is there any data in this area, or is anybody aware of work being done?
I'm not aware of it. And it's not something that the data, the data sets that I work with would be able to look at. I think it's something that you'd have to collect prospectively, probably through a randomized controlled trial to look at that. So maybe that could be a topic for future study.
Right. I think we're getting close to closure here. There was another question in here with respect to scientific data moving towards public forums. Is this helping or improving public confidence in science? So what strategies could we use to fully explain ambiguity in science with the public? Very interesting question here from Archie.
Maybe I'll start, since I think I introduced that one. Is, first of all, I think it's a good thing that we have more open science and we have more public discussion about these issues. So I think in the long term, it will be good and healthy. I think we need to also work on improving science literacy, numeracy in the overall population so that they're able to make these decisions. I think it also relates to the earlier discussion on addressing hesitancy. I think what's been unfortunate during the pandemic is that it's sort of rushed out without always the context. And so again, open science is great. Jeff showed some pictures of preprints that are posted up and allows us to share data and results really quickly with the scientific community. But, particularly in the early days of the pandemic, I think the media are a little bit more savvy now. A lot of preprints were being presented without any context, that they're not yet peer reviewed. And so, that leads to confusion and disagreement. So while open science is a good thing, we have to really be open about that. And then, as I said, I think what we have to do a better job is being clear when the science is uncertain, when the science is conflicting, and be frank with the public about that, and explain the reasons and why the decision or the policy that's been recommended has been reached. And again, I think, Jennifer said this, like, that does not translate into sound bites. It does not translate into tweets. And so, people have been very critical of NACI, but, I think they've been critical of the headlines that have been generated about NACI. If you actually go and read their statements that get posted up on the website, they provide the basis, they provide the logic and deliberation that they've done. And it's there, but it's going to wind up being a 10, 20, 30 page document with lots of references to outline how they got there. And that doesn't get communicated in the media. And I don't think the media have to go through all of that, but the media have to, I think, say, behind this headline, there is this document that people have gone through. And I think we have to be more open with the public about the processes going on. Because otherwise it does wind up looking like, as I showed that picture of, Mona Niemer versus Bonnie Henry or whoever, that the scientists can't agree. So maybe it's not, we shouldn't have confidence in it.
All right, I think we've pretty much covered many of the questions that have been posed in the questions and answers.
Terry, can I pick up on one thing, and it relates to the point that Jeff just made about, countries that have kept their borders closed can't keep them closed forever. And also, I think there was a question from John McLaughlin. It's been said many times, this isn't going to be over until everyone in the world has access to the vaccine. And I hinted at this when I was presenting the data. And as much as we'd like to say we're laggards, we're really doing very well globally. And there was a commitment a year, I guess it was probably launched about a year ago as well, the COVAX initiative, where the richer countries agreed to sharing the vaccine. It really, unfortunately, went by the wayside. It had no choice but to rely on the Serum Institute of India to supply the vaccines for delivery to the countries that were going to get it free of charge, because the rich countries would not allow any of their vaccine supply to be moved out. And then, as we've seen, India wound up having one of the worst outbreaks in the world, and so made the same decision. Remember back in March, we were getting COVID shield vaccine from India here in Canada, right? They kind of, I think the Indian government quite rightly said, okay, well, if the US, the EU, all these other countries aren't going to be sharing the vaccine with the rest of the world, why are we doing it and putting our own population at risk? And so Africa, a lot of parts of Latin America are not getting any vaccine right now because of where we wound up. And I think that is, it's a dismal outcome to have had. And it's going to mean that the pandemic is going to be prolonged because we're not sharing that vaccine. I don't have a solution, but it is something that for the future globally has to be looked at.
Terry, may I just add just slightly to what Vivek is saying, which I think is really important. And I think in the earlier conversation today that was talking about whether or not we should be developing our own internal Canadian capacity for vaccine production, one of the things that was back in my mind was for whom? And I think what Vivek's observations really point to is that there's opportunities here, first of all, to acknowledge our interdependency globally. Shutting borders is a reaction, but it tends to sort of parochialize ourselves and to disconnect us from the fact that we actually are part of the global community. Second, when we think about domestic production, there is an opportunity to think about that in terms of in a way that it fosters sharing and fosters collaboration and fosters sort of a global vision around that. But that really does tap into sort of our deeper sense of it being part of a larger human community, sort of the sense of global solidarity and what our obligations may be. So as Canadians, I think we need to be asking ourselves the question, if we are willing to receive, what is our reciprocal obligation to provide in ways that actually fosters those strong dependencies for the good of all, rather than just simply for our own parochial self-interest.
Thank you, Jennifer. Mark, Jeff, do you have final comments in this area?
I mean, as has been said, if the disease is anywhere, it's everywhere. And one of the things, Canada has been conscious of its effort through the COVAX facility and donating money to COVAX. We bought some vaccines, but at the end of the day, it may very well be that we end up with more vaccines than we need for Canadians. And I think the intent was always to donate and contribute to that internationally. So with time, I think that will come, and we'll continue to see Canada play a role there.
Thank you, Mark. Jeff?
I guess what I'll say is, like, I guess there's the question of, in Canada, we took the first doses fast strategy, and, other countries are going to have this same issue where they're going to have limited vaccine supply, and presumably, or hopefully, they'll also adapt the strategy. But maybe we need to think more globally, that maybe all countries, we should think, maybe we should be, this is probably not going to be popular at all. Probably will not, no politician will suggest this, but maybe we should be doing first doses in other countries before doing second doses here. I would just put that out there as a thought exercise, but I don't think anyone would really advocate for that, or any politician would advocate for that.
Thank you. I think we're all keen on the idea that we need to have a global kind of capacity, and despite the discussions that have gone on, we still have a lot of majority of patent activity that somehow inhibits, the transfer of products to places like India and places in South America and Africa. So it's one of those sad realities that we have to find a way through, and somehow we haven't been able to do it through WHO or through other routes. So maybe something, a project to be thinking about together as we go forward. So with that, we're just closing on 11:30. I just want to thank all of our panelists, Mark, Vivek, Jeff, and Jennifer, for a tremendously stimulating discussion today, and for all of the attendees who took the time to join with us today and participate in the discussion and questions. It was extremely helpful. So thanks to all, and safe travels, and enjoy the rest of the day, and bye for now.